Welcome to Duke Spine Institute. You are joining us for one of the most difficult surgeries we've ever done. This poor patient hurt his back, and he got into the hands of a typical spine surgeon who fused the hell out of his lower back. You can see the screws, rods. They went through the back, they went through the front. This is just horrible surgery, by the way. So they went through the front and put in a plate and a cage, but they never took the herniation out. Now he's got the herniation. It was pushed further back by the cage, and now it's hitting on his nerves, and I have to go in and unpinch the nerves by removing the herniation. Sloppy, sloppy work. Then he had screws and rods put in the back, and that's sloppy as well because there's no cages that were put in where the discs are. You're supposed to put cages when you go in. So this is a cheap, easy fusion that was done. And of course the patient's developed adjacent segment disease at L5-S1 where he never fused, and he's got a stimulator in. They just milked him for millions of dollars. They milked his insurance for millions of dollars. He's in so much pain. He came to Duke Spine. I realized what was wrong, besides the fact that the surgeons just milked him for every dollar, his insurance for every dollar they could. And I told him that I think your problem is still that disc at L5-S1. We can go in and try to fix it with the laser. So that's what we're going to try to do. I'm trying to go from both sides because he really needs it from both sides. But I don't know if I can get in. I mean, it's a miracle I actually got in on the left side. I can't believe I did, but I did. On the right side, I'm trying to get in. So we're going to fix L5-S1 disc with the Duke laser disc repair bilateral to treat his back pain. We're also going to remove his stimulator later on. You're going to get to watch that. Spinal cord stimulators, in my opinion, are an absolute horrible procedure that should not be done for back pain. Spinal cord stimulators are good for chronic radiculopathy that cannot be operated on, and for peripheral neuropathy that's end stage and severe. Shot? Wow, I might have actually gotten there. All right. He's not liking that. AP? Any questions? Feel free to type them up. But this is, you can see the result of multiple fusions on this guy from the front, from the back, and honestly just greed from the surgeon. Doing all this huge fusion. You can see his fusion scar, by the way. Let's show you guys where they cut him. They cut him from here. You can see the top of the scar here, Henry, all the way down. This is his surgery. Now you wonder, why do patients who have fusions, why do they do so bad? Because the surgeons are cutting their muscles out, destroying the muscle. They're cutting the bones and ligaments from the back. They're putting in screws and rods. Massive. His stimulator incision is right there. We're going to open them up later, take that out. Those are the leads, and then he's got a generator incision right there. You can see it. We're going to take that out later. So he wants his stimulator out. All right, very, very difficult surgery. I'm trying my best here to get into that disc at L5-S1. So here's what I'm going to do. I'm going to put my dilator in on the left, and then we're going to go to the right and try to get back in. I'm going to do a discogram shot. All right, there's the die, AP, shot AP. Now, remember, this disc was, they tried to fuse it. Yep, you can see the die and the disc right there. He's got a listhesis here. If you have questions, feel free to ask them. In the meantime, Henry, let's share with our audience what is the most common causes of back pain in patients that have had back pain for a long time. We call it chronic lower back pain. There are about 30 things that cause chronic lower back pain, and this video here is going to show you all 30. I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us. Okay, welcome back. You've seen our video on the 30 different causes of back pain. Now, let's get back to this patient. Look at those screws and rods. Each of those are screws. There's 2 there, there's 2 there, there's 2 there, there's 2 there, and it keeps going up his spine. So every screw that surgeon puts in, it's more money in the bank. Every plate they put in, more money in the bank. So what's happening here? Now you can see our tube, our endoscopic tube. I was able to get it into L5-S1 on both sides. I got a tube on the left first, and we're inside that disc. There shouldn't be any disc material left. The surgeon was supposed to take all the disc out and then put a cage in. Instead of taking all the disc out, he only took the front half of the disc out, put a cage in the front half. So the whole back of the disc got shoved backwards towards the nerves, and that's what's causing all this poor man's symptoms. So by miracle of God, I was able to get in to L5-S1, which is almost impossible to do. It's impossible to get in L5-S1 for most surgeons, and then to get in with a collapsed disc, with a spondylolisthesis, with screws and rods, it's almost impossible. It's a very difficult case. But we're here, and I'm going to show you what's inside. We're going to actually see this cage that was put in years ago into the L5-S1. And you're going to see a bunch of herniation too. So let's get going. And if you have questions, feel free to ask. But we're going to go down the rabbit's hole. We're on the left side at 5-1. All right, there we are. We're inside that disc, and we're right behind that cage. And we're in the disc, and there's not supposed to be any disc here. But look at all this disc material. This is the blue stuff, the white stuff. So I've got to take this out because it was supposed to be taken out during the fusion. Not only did this poor man have a fusion, a big giant fusion he didn't need, but he also got a stimulator. Why not? You know, if you're at the $500,000 mark in what you cost the poor insurance company, you might as well make it an even million. These spinal cord stimulators rarely work. And look at the cage. There's the cage, guys. You see it?
Yes, we do.
That's the beige colored thing down there is the cage. We normally don't see cages after we put them in. But this poor man, the surgeon never took the herniation out, just left it there and stuck the cage in through the front. Unbelievably bad surgery. Honestly, I have no idea who the surgeon is, the spine surgeon that did this. It wasn't me. I don't do this kind of shoddy work. That's why it's important you choose the right doctor to do your back surgery. Otherwise, you just keep living in pain for years and years and years, and you have to keep getting more treatments. All right, any questions from our audience while we bring the laser in and start removing the disc material that was herniated that the other surgeon was supposed to take out before he put the cage in?
Yes, we have a question coming from Frank on YouTube.
Hi, Frank.
Saying, Dr. Duke, how are you? How long is normal for the incisions from laser disc repair supposed to bleed?
Oh, they're not supposed to be bleeding this long. That's for sure. All right, so I would say maybe 3 days at most. But it depends on the patient. And if the patient has blood thinners like aspirin and stuff, it could bleed longer. But that should not be bleeding more than 3 days. If that's the case, we need you to be seen, and we're going to need to evaluate you and put on some staples, okay? We're going to need to put some staples or sutures in. And it could be just that the way you're laying on it. You've got to not lay on those incisions in bed. You've got to sleep on the side and stay off of them. But they should not be bleeding more than, say, 2 or 3 days maximum, okay? So you need to come see us so we can see what's going on. All right? I mean, if you're oozing some serosanguinous fluid, that can be okay. Some fat, you know, if you got some fat necrosis going on from the surgery, it can be normal. But I would be very concerned. I would want to see my patient back after 3 days of drainage from an incision. If the drainage is going beyond 3 days, I must see them back. I hope that answers your question. All right, so we can see the cage. You can see the end plate of S1 right there. This is all herniation that should have been removed during the original surgery, the fusion that he had, but it wasn't. So the surgeon did a very shoddy job. There's the tear in the annulus, and this is all part of the herniation right here. Any questions?
No current questions, so we do have a comment coming from Frank once more on YouTube. Saying, I still have a lot of soreness in my lower back on both sides, and when I try to walk, I get a lot of pain in my lower back, which radiates into my thighs and on the front of my legs. I still have some bleeding, I'm sleeping on my side, and I'm also sleeping sitting upright in my chair
Yeah.
because I can't find a comfortable position in bed.
Yeah, so what I want you to do is I want you to come back and be seen. I need to see you in my office. I need to see you. So if you can be here tomorrow, that would be best. I'll have Dr. DeMola evaluate you, get some pictures, but it's normal to have soreness. And the other thing about patients that have this surgery is if they have more than one problem, like more than one cause of the back pain, you guys just saw the video, 30 causes of back pain. So if you have 8 causes and you only have surgery on 4 of them, you still got 4 things wrong that need to be fixed. And those 4 that are left over would be the 4 that are causing the symptoms that you would be having. I'm just saying hypothetically, okay? I'm not speaking about Frank or anybody else. I'm just saying we have a lot of patients who have more than one problem, but they decide they're only going to get one problem fixed, for example, or 2 problems fixed. Then they end up coming back because they have pain from those areas that we never fixed. That said, for Frank, I want to see you tomorrow in the office. I want you to come in and see Dr. DeMola. All right? And every patient that I operate on has my phone number, my cell phone. And they should be calling me and sending me pictures of things. Okay? So I would recommend if you're having anything going on, you should be taking a picture and sending it to my cell, and you can communicate with me on my cell. But you really need to be seen here in the office by our doctors. I myself will be back in on Monday. Dr. DeMola is here on Friday, and Dr. DeMola can see you if you can get here tomorrow. Otherwise, Monday you can see me. Okay? Great question. I'm glad you asked. But drainage should always stop by around 3 days after surgery.
And at this moment, no current questions.
Yeah, and most patients, we don't expect any drainage at all. But obviously, some patients are taking blood thinners or antiplatelet agents, so they're going to ooze some blood after the surgery, and that oozing, can be made worse by or aggravated by movement of the skin edges or sweating. The bandages get loose and come off. So there's a lot of factors, but if I ever hear from a patient that they have some issue with their wound, I want to see them back right away. I don't want any delay. I want to assess the wound and make sure it's healing properly. And of course, reinforce it if we need to. So, any other questions?
Yes, we have a question coming from Frank once more, asking, should I just come there or call to make an appointment?
No. Come. Just come. Yeah, just come. You don't need a call. Our office is always open to our patients. We don't run interference. We want patients to come in and be seen. So if you can come tomorrow, great. If not, come Monday and I'll see you. So I can just check you out, make sure you're okay. Okay, I would prefer you come tomorrow morning, and see Dr. DeMola. Then I can work with Dr. DeMola to figure out what's going on and we'll get it addressed properly. Okay? All right, so there's the cage down there. Let's see if I can show it to you guys again. Remember, this cage was put in through the front. We're going through the back. This is a very common surgery, putting a cage in at L5-S1. I never recommend that to patients because you have to go through the belly, basically. There's the cage right there. All right? And all of this is herniation and scar tissue. So that's what I'm working on. This is what was pinching his nerve right here, this herniation. Again, fusion should be avoided at all costs. The only time you should get a fusion is if you have really a serious car accident with a fracture dislocation of your spine. It's unstable, needs to be fused. Or a tumor or an infection that's destroyed your spine, your bones and ligaments, and caused massive instability. Then I would consider a fusion as well. But for degenerative conditions or herniations like disc bulges, disc herniation, stenosis, spondylolisthesis, I strongly recommend you avoid invasive, dangerous procedures like spinal fusion. All right, let's show the audience how the Duke laser disc repair gets rid of pain, back pain, from a disc injury.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. We are in the middle of repairing this left L5-S1 disc issue. All right, I need that irrigation. How is it coming? Still not getting good flow. It's barely dripping. Jordan? And Henry, you mentioned a question.
Yes, we have 2 questions. This first one is coming from, forgive me if I've mispronounced the name, Eniola on YouTube.
Amiola, welcome.
Eniola asked, "Hi, Dr. Duke Machen.
Hi.
I am a pre-med student currently studying for my MCAT. I love your
Great.
live surgeries. They are so informative.
Thank you.
I was wondering, what is the name of the surgery you are performing here, and also what is it that we are seeing you are sucking up right now?"
Yeah, great question. Thank you, and good luck to you for medical school. I really hope that you make it, and when you do make it, you will make it. I want you to remember that the most important reason you went into medicine was to help people be healthy, be well, be healthy, be well. And never do what's best for the insurance companies. Do what's best for the patients. Okay, your patients. And then you will be successful. You will be very, very successful and loved and appreciated by your patients. Okay. So that said, what we're doing is a procedure. This is endoscopic spine surgery. In other words, we're operating through what's called an endoscope. An endoscope is a long metal tube that has lenses and light source and a camera that can attach to the back. And the endoscope is allowing me to see inside a disc. And specifically, we're in the back of the disc at L5-S1. And you can see a lot of scar tissue here from inflammation from the herniation that this patient had. So this is the cause of his back pain that he has. And we're fixing that for him right now. Now, how do we do that? We use the laser. You see that laser? What's happening is the laser's removing all this herniation, basically. The way it does is it releases laser energy, electromagnetic radiation, right onto the herniation, which is, by the way, partially calcified. You can see that. And the laser energy gets absorbed by the piece of herniation, and it causes that piece of herniation to literally blow up, explode, basically. So we're vaporizing this pathological tissue within the annular tear in the back of this disc. Okay? This is not a discectomy. This is a Duke laser disc repair procedure. We're going to end this stream in about 15 minutes, and we're going to start our last case of the day, which is to remove this same patient's spinal cord stimulator that some other greedy pain management doctor put into him when they should have instead sent him for a treatment that actually works to eliminate back pain, which is the Duke laser disc repair. Just remember out there, there's lots of companies that want you, the doctor. These companies cannot give your patients medicine. You have to prescribe it as a doctor. So these companies are in bed with doctors now, and they're controlling doctors to use their drugs and their devices. And their drugs and devices are not helping patients. A lot of them are harming patients. So that's why we're raising awareness about this problem. This is the lateral herniation at 5-1. I'm just about done with the left side, and I'm going to move on to the right side. Luis and I are going to switch sides in just a moment. But this is all part of the herniation. Any other questions?
Yes. These next two questions are coming from Faisal on Facebook. First
All
question.
right.
First question asking is, "Hi doctor, don't worry, I will come to see you soon. I want to ask you, there are some surgeons saying that 90% of disc herniations heal by themselves and recommend different types of anti-inflammatory medication for the pain.
Sure.
Can you respond to that, please?"
Yes, those surgeons are wrong. I don't know who they are, but they're 100%. They're 90%, I'm 100%. Those surgeons are 100% wrong. Disc herniations never ever heal on their own. On the internet, you can go and see some pictures where those doctors will show you after their Vax-D treatment or whatever treatment they're doing, their nonsense treatment, that the herniation is gone. But what they do is they switch out the MRI and they show you a different area of the MRI or a different patient's MRI. It's just a scam. Disc herniations do not heal on their own. They may get better for a little while where you feel less symptoms, but the herniation is still there, and it's just a matter of time before that pain comes back or symptoms come back. So it is incorrect. Disc herniations never heal on their own. And that's based on me treating 150,000 patients with symptomatic disc herniation, okay, over the years, and looking at 500,000 MRI scans. Remember, I've been doing this for 29 years now. All right, we're done here. Remember, this was L5-S1 on the left. There's some fat, there's the nerve. We're going to go to the other side. How is our patient doing? All right, we're switching sides because we're done on the left. Any other questions?
Yes, the few more questions. Next one from Faisal once more on Facebook asking, "Doctor, how big is your surgical team when you operate in the operating room, and what do they all do?"
Well, Faisal, it's a good question. We have an anesthesiologist, we have a surgeon, we have an x-ray technologist, a laser technician, a circulating nurse, and that's the bare bones of what we have. Sometimes we have two nurses. For example, when nurses walk off the job and abandon the patient, we need another nurse, right? So sometimes we'll have two nurses. So long story short, that's the team right there. All right, Luis, you can do this. We're going to get to the patient's right side. And by the way, all these people are constantly working. None of them are standing around doing nothing. The anesthesiologist has to monitor blood pressure, respiration, CO2, everything. And he's constantly, administering medication, checking vitals, using the monitors. The x-ray technician, he does more than just the x-rays. He also helps with the laser and the endoscope. The laser technician helps with the laser, the endoscope, and everybody's running around doing stuff. So that's something you don't see in the background. Nobody's standing around doing nothing. The only person that's really just doing nothing is the patient. And that's the way we want it. We want the patient comfortable, sleeping, and just relaxing, doing nothing. All right, what are we doing here? Can I see this? Do we have an x-ray image? Excuse me. Go ahead. Any other questions?
Yes, we have another question coming from Eniola, once more on YouTube,
Sure, Aniola.
asking, how do you decide on whether to do a discectomy or a disc repair when dealing with a herniated disc?
That's a great question. We never ever do discectomy. Discectomy is an old surgery that should be discarded. So remember, discectomy and discard, they rhyme. Discectomy is invasive, it's bloody, it's painful, it makes scar tissue, it removes the facet joint, part of it, it removes the ligaments and bones that are normal, that are necessary for the patient to keep. But all this damage to the patient's body is done because that's the only way to do a discectomy. That's why I stopped doing discectomy, because it's so damaging to the patient. This surgery is non-damaging, non-invasive. We're just making a small cut in the skin, and the rest of the body underneath the skin is preserved normal. We don't do anything to hurt the patient's spine or joints or ligaments. It's all kept normal. Sean? Great question. So we don't do discectomy anymore at Duke Spine Institute. That's an old surgery. It's still being done by many surgeons, and it should not be done anymore. So if somebody's recommending discectomy, my advice, come to Duke Spine and get a better surgery done. All right, we are now next to the hardware. We're making our way down. Not yet. And I'm trying to get past all the scar tissue. A lot of scar tissue from his fusion here. Just on my way down to the disc. I'm probably going to have to use the tamp. Boy, it's putting a lot of stress on that guide wire. Shot? Very, very difficult to get down here. But you see how the dilator follows the guide wire? That's the beauty of this technique. I was not the first doctor to use a guide wire. Dr. Selding. Apparently Dr. Seldinger, I'm being told, was the first doctor to use a guide wire. Brilliant. He's a little bit moving. It's called the Seldinger technique, I'm being told. Wonderful idea, great surgeon. I'm very happy that he developed this technique. But this, I use the guide wire to get to the herniation. Really? We use guide wires for lots of things, mostly vascular access. All right, get that guide wire out. All right, I just bumped up against the cage again. There it is. We're going to go in on this side and remove the herniation that surgeon left. Avoid fusion, avoid spinal cord stimulators if you can. These are old technologies, so is discectomy. You don't want those surgeries. They create more problems after the surgery than they solve during the surgery. This Duke laser disc repair is the best, most advanced treatment in the world for a disc problem. All right. Looking good. We've got one more disc, and then we're going to take out his spinal cord stimulator. He asked us to remove it. He had it put in. It's not helping him. Many spinal cord stimulators get put in. The doctors and surgery centers and hospitals make billions of dollars a year doing spinal cord stimulator implants, and then they stop working. If they even work, they stop working usually within a few years of getting it in. All right, we're inside that disc now. You can see all the scar tissue, and it's kind of reddish white. That's all blood, vascularity, scar tissue. Again, we never should be doing this surgery. If the fusion was done properly, we wouldn't be here. But it was not done properly. They left the herniation here behind the artificial disc. All right. Any other questions?
Yes, we have two more questions. Next one from Faisal once more on Facebook, asking, did the previous surgeon not decompress the nerve properly?
Correct.
Hence why you're going in to repair the disc.
Yes, that's right. When you put a cage into the disc space, the surgeon is supposed to remove the disc. They're supposed to do a discectomy. You're supposed to take all the disc out as much as you can. Usually you can get about 80% for this type of technique. But this surgeon did not do that. Is he moving or is that you? You guys got to tell me when you're going to do that so I'm aware. The surgeon did not remove all this disc material. Look at it. There's the cage right there. You guys see the cage?
Yes, we do.
And this disc is not even fused, so he never fused at this level. It's just not a surprise he didn't fuse because the surgeon never took the disc out. You have to take the disc out and fill the disc space with bone in order to promote fusion. There's the cage right there. You guys see that?
Yes, we do.
So we're inside his disc now looking at that cage. I got 5 minutes on this. Great questions from our audience, by the way. Thank you for asking.
Next question is coming from Eniola, once more on YouTube,
Yeah.
asking, I saw your no-touch laminectomy in another video. That was so cool. Did you
Yeah.
come up with that technique?
Yeah, that's pretty interesting, isn't it? No, I did not. The no-touch laminectomy is one that I was taught in residency. I went to a top neurosurgery training program here at Florida, University of Florida in Gainesville. And the no-touch laminectomy was something that was developed by another surgeon, but it was taught to me during my residency training by my attendings. It's a much better technique than going in and using a kerosene rongeur to remove all the lamina 2 millimeters at a time. Much better for the patient too. So I can't take credit for that one. All right, so far everything's going well. Once again, we're inside the L5-S1 disc. We're coming in through the right foramen. We just went past the screws and rods that were stuck in his back by some other surgeon. And you can see a giant tear right there. This patient would have done fantastic if we would have gotten to him first and done the Duke laser disc repair. He would not have needed any fusion at all. That's why we're trying to get the word out so people understand fusion is no longer necessary for disc injuries or disc problems. Spinal stenosis, radiculopathy, back pain, neck pain. We can fix those problems with the laser. All of this material should have been removed during his first fusion. There's a piece of fusion right there. You guys see that? That's a piece of bone graft, but it's loose. It's not fused. It did not fuse to the bone below it. But that surgeon stuck that in there. It just never did its job.
We have another question.
Sure.
Coming from Frank, once more on YouTube, asking, Dr. Duke, now that you removed all the discs right there, will it now fuse on its own like it should have from the beginning?
That's a great question, Frank. The answer is no, probably not, because it's not just about removing the disc, it's also about putting bone graft in here. And I'm not putting any bone graft. When I talked to this patient about the surgery, I never discussed putting bone graft in here. So I can't do it now. It would be basically the wrong thing to do because the patient never gave me consent to do that. So I can't do something he didn't give me consent to do. Great question, though. I kind of wish that I had, asked for consent to do the fusion, but what's going on? Why is Nikki scrubbing?
Oh, just for the next step. I want to
Oh,
I'm here assisting you.
fine. All right. Sounds good. I'd just like you guys to, probably 3 to 5 minutes with the disc, and then we'll go to the removal. Any other questions?
Yes, we have a question coming from Eniola, once more on YouTube, asking, in what case would a fusion be a good idea, or is it just a never?
Fusion is good when The surgeon has a new Mercedes they want to buy. Fusion is good when you're friends with the company that sells the screws, rods, and cages, and you want to help your friend out as a surgeon by putting them in a patient. Fusion is good for the hospital because the hospitals make anywhere between $50,000 to $250,000 for a fusion surgery. Fusion is good for the companies like Medtronic or DePuy or Medtronic, Sophomordanic, DePuy, Alphatec, Nuvasive, Globus, all the companies that sell screws, rods, and cages. Fusion is good for pain management doctors that treat the patient's back pain after their fusion. Fusion is good for anesthesiologists who bill per hour and they have long fusion surgeries. But notice the one person I never mentioned in there was the patient. Fusion is not good for the patient. So why are we recommending fusions? I think the answer is obvious. Each one of those screws makes the company that manufactures those screws, they get about $1,000 for each one. I saw 10 screws. So that's $10,000 that goes to the company that made these screws. And it cost them less than $100 per screw to make. So they spent $1,000 and they made $10,000 on just the screws alone. Cages, a lot of times, are $5,000 for a cage. Of course, it's basically a piece of plastic. So it costs the company maybe $100 to make it, and they're getting $5,000. So you do the math. You're getting $10,000 in screws, $5,000 in cages, and then there's something called a rod. They're going to get about $1,000 a rod, and that's just a piece of metal. And then, of course, there's the set screws that lock the rod to the tulip head of the pedicle screw, and those are, a couple $100 each, so maybe another $1,000 there. So you're looking at, on a typical back fusion, the company that makes the screws and rods is going to get around 20 grand, 25, 30, 40 grand, depending on how many levels are fused and what's used to fuse. The hospital is going to make 100 to 200,000 on a big back fusion. The surgeon's going to make 30, 40,000. Compare that to this surgery where there is no money being made by the implant companies because we're not using any implants. The surgeon makes $500, not $40,000. I used to make $40,000 doing those fusions or more. That's where I made all my money in my career. But I don't recommend them anymore because this surgery is now available. So, not only is this a better surgery than fusion, safer, better for the patient, but it's also cheaper, a lot cheaper. But doctors aren't going to recommend it because they're going to make a lot less money. And it's the surgeon who recommends your surgery, remember. So in the end, it's the surgeons recommending screws, rods, cages to their patients.
5 minutes left.
You're so funny. I've already said 5 minutes. That was 3 minutes ago, which means 2 minutes. I got about 2 minutes left. Is that okay? And then we got to take the stimulator out. Are you okay with that? All right. All right, it's just about done. I got about 2 minutes left. And this laser, thank God we have the laser because otherwise we'd never get any of this stuff out. This is hard as a rock, like concrete. All the scar tissue from that surgery is proven to be very, very difficult to get this fixed. But we're getting it done. Any other questions, Grabber?
Yes, we have a question coming from Faisal once more on Facebook asking, I think that previous surgeon should pay your bill for this patient.
Yes.
Doctor, if you may have cervicogenic headaches, what levels would you suspect may be causing it in the neck? C1-2, C2-3, C3-4?
That's a great question, Faisal. The most common level to cause cervicogenic headache is C5-6. The second most common is C6-7. So there you go. Look at that, huh? That's supposed to be the fusion right there. It didn't fuse. You see that, Berndes? That's the bone graft that was put in behind the cage. At this point, I'm just removing this bone graft that never did its job. All right. Just about finished. I wonder about Faisal. I wonder if Faisal is a doctor. He asked some interesting questions.
He does indeed. If he ever answers what he does, I'll let you know.
All right, well, we're done here. Looking good. Yep. Looking very good. All right, folks. We're going to come back in a few minutes with our last surgery of the day, removal of a spinal cord stimulator. This spinal cord stimulator, it costs the hospital $20,000 to buy, which means that the hospital paid $20,000 for you're going to see it. It's a tiny little thing that probably costs $50 to make it. I'm sure it's been made for somewhere around $50. Of course, the company that makes them will never tell you how much they pay to make them unless you sue them. So, my guess, $50 generator battery, $1 plastic lead, and then of course they charge $20,000 for it. So they're selling a million of these a year, and they're making a profit of 19,000. Let's just say 20,000 per. So what's a million times 20,000? Huh? Anybody? Come on,
Million
Nikki.
times 20,000?
Yep. 20 billion. Wow. All right, so let's say they're making 20 billion a year profit. Why would they want to stop that? They don't. So they're going to keep telling doctors to put these stimulators in patients even though they don't work. And it harms patients. Now these are my opinions, okay? They don't represent the opinions of Duke Spine. They're my opinions, Dr. Duke Majan. And truth is, it's based on 25 years of having put in spinal cord stimulators. I never put that many in because they never really worked, and there was always a better treatment. Okay, we're done. Let's end the stream, and we'll come back with our stimulator removal.